Good morning all, and welcome to this meeting of the Clinical Care and Governance Committee of the Integration Joint Board. Thank you all for coming along this morning. I'll just begin the meeting, I think. First of all, are there any apologies? Have we had any apologies?
We've got apologies from Andrew Muddy.
Okay. And are there any declarations of interest? No. Okay. In that case, we'll move on to the item number 3, which is the minute of the previous meeting. First of all, can someone agree that this is a correct minute of the meeting? Yep. Nobody. And are there any matters arising from it? No matters arising? Okay. In that case, we'll move on to the action log. Now, the action log, I think the item on care opinion is on the agenda, and the other item is completed. So there's nothing to read on the action log. No. Okay, thank you. We'll move on then to agenda item number 5, prescribing proportionate care project. Now, is this Gordon or Lynette or both going to speak to this one?
Chair, it's Gordon Mackenzie. Lynette is with me. If there's any tricky questions about occupational therapy practice, I'm sure she'll jump in and help me out. Thank you, Chair Committee. On the face of it, a fairly positive report, I would suggest. Gives you the background to the prescribing proportionate care project, what we're doing, why we're doing it. The up to item 4.11 is mainly background, and I'm going to assume people have read that. There is some detail in the report about progress to date. The timing of the data collection and the report writing meant that we've only got the data in front of you for August, September, or to that point, which shows benefits from the project, undoubtedly. You can see as we roll forward that that benefit is accumulating. The latest figures that we have are that the project has probably saved something in the region of, or will save over a full calendar year, something like 6,000 hours of care. That equates in monetary terms to roughly £180,000. So we're already seeing substantial benefits in terms of the amount of care saved financially. Well, this project wasn't about finances, but it does show that we're making a decent return on our investment. Importantly, we're seeing real benefits for service users, and we're freeing up care package time to put towards service users who currently don't have packages of care or need increases in package of care. That's a fairly modest amount, I have to say. At the moment, we're talking about 11 or 12 packages of care being the sum total of what we've saved, but it's still a contribution towards the pressures that there are across the system. I think one of the things that I would highlight in the report are the challenges in rolling this out. We had really good engagement, excellent engagement at the start of this process, especially during a very difficult time of pandemic. Got a lot of people along to be trained in the assessment, a lot of enthusiasm for it. It's been really, really difficult to free up staff time at the rate that we wanted to in order to carry out the assessments and provide and deliver the new type of care. I suppose we call it the new type of care that we're trying to deliver here. So the progress that we've made to date, although it's positive and we can see the benefits, it's not been at the rate that we hoped we would be able to. We're looking at a lot of different ways to try and increase that. It's a lot of it is down to staff time, particularly qualified occupational therapists, physiotherapists and the like, who are best placed to carry out these assessments. We're really, really challenged in that area in the community. We are, I wouldn't say desperately, we are trying everything that we can to recruit additional OT into the OT support into the services. In order to do that, we've managed in the last couple of weeks to free up part-time OT to help us with this, and we'll push it forward through our in-house service and see if we can get some more traction on this. So overall, a positive picture. I would have liked it to have been better, quite a lot better, but the challenges I think that we've all got in terms of staff availability have impacted on this project like it has on many others. Thank you. Happy to take questions.
Thank you, Gordon. It's really good to have a report that's, although perhaps not going as far as you had hoped, as quickly as you'd hoped, it's a win-win. It both saves money and increases the availability of care packages and enables more people to stay safely in their own homes. That sounds what's not to like. So perhaps more power to your elbow. Anybody got any questions or comments they want to raise? Yes.
Thank you, Chair. Gordon, just to clarify, you mentioned the number of hours per year that we would expect, and then subsequently said quite a small number of packages. Is that, to be clear, is that the number of packages we're saving right now, or is that the number you can expect annually? It's just for clarification. Thanks.
Sure. That's the number of packages we're saving right now. So broadly speaking, 10 care packages are average about 10 hours per care package. So that's 100 hours a week. You gross that up over a year, and that's 5,000 hours. So it's a little bit more than that we've, I think it's 11 or 12 care packages equivalent that we're at the moment. So that's how we got to that big number, and that's where it comes from. So you can see that, you know, even a small benefit, the limited progress that we've made has already had a significant benefit.
Any other questions, comments? Can I just check, I take it that there is a follow-up happening so that we can get comments from the people who are receiving this service so that we can ensure that we can improve on it?
Yes, we are doing that at the moment. I think one of the issues that we've come across, thank you for asking this question, Chair, it's quite a tricky one for us. We are having to chase up practitioners in order to gather that information. So we will continue to do it for a couple of months more until we feel we've got a body of evidence, qualitative evidence around it. I think, but further forward, we're looking to minimise the amount of data collection. We will still be getting that information, and it will be held on service user case records, but we wouldn't be looking to gather that as a matter of course for reporting to the committee, if that seems okay with you.
Any other comments or questions? In that case, I think we've considered and commented on the content of the report and the progress being made. Thank you very much.
Thank you.
And now on to agenda item 6, the overview of the local oversight arrangements. And I think that's yourself, Suzanne.
Yep, thank you, Chair. The report presented today is a summary of the range of Forth Valley and Falkirk groups who lead in key areas of activity such as public protection, adult support and protection, clinical and care governance and care home assurance work. And through reporting on this work of these groups, it's intended to provide assurance to committee members that the arrangements are relevant to the scope of the partnership. So the report provides updates on the Public Protection Chief Officers Group, and they have recently received a report on the learning review, which was led by the Adult Protection Committee. The COG agreed to support 4 recommendations presented to them from this work, and that's set out at 4.6 of the report. Further work will be done to implement these, and a meeting will be held with the Mental Welfare Commission to provide them with the findings of the review and improvement activity. The COG also considered their risk register, and that was fully discussed, as well as receiving data summary reports and scrutinised adult support and protection and child protection performance in these areas. We've also provided an update on the recently established Health and Social Care Partnership Clinical and Care Governance Management Group, and this has been meeting bi-monthly since its first meeting in July. We've established an agreed reporting template that services use to present issues, pressures, mitigations and successes. A learning from incidents subgroup has been established to identify improvements in the handover of care at point of discharge, and the report sets out the initial work done by this group. And the committee is asked to note that a further update will be presented once this work's been concluded. Section 6 sets out the NHS Forth Valley Clinical Governance Committee agenda and an update, as well as the Forth Valley Clinical Governance Working Group. We've also provided an update on our care home assurance work, and this committee, will be aware, has been regularly reported to them, and we've included an update on the completed care home reviews and the care home assurance group. At section 8 of the report, we've provided an update on the work of the Adult Protection Committee and covered their learning review work earlier in the report. An update on the joint work with the Child Protection Committee in Police Scotland to protect people vulnerable to being drawn into terrorism set out in the report as well. A joint Prevent Refresh presentation took place in October around this work. We'll also bring forward to future meetings the biannual report of the Adult Protection Committee and work being done around the adult inspection report. So once that's been considered by Adult Protection Committee in December, we'll bring forward a report to committee here. We've included as a new addition to the report an update on suicide and drug related death prevention work, and that's set out at section 10 of the report. There's been quite significant work that's been taken to develop the drug related death review process, and a significant number of reviews have been completed. And from this, an action plan and learning points has been generated. So there is ongoing work to also develop a Forth Valley suicide and drug death prevention plan, and as noted, it will be provided an update to future committee. So in conclusion, committee is asked to note the recommendations of the report at 2.1, and I have colleagues that represent many of these groups at the meeting today here, so if there are any specific questions, you can pick up on those. Thank you.
Thank you very much, Suzanne. Before I put it out to questions, I would just maybe like to ask you to say a little more about paragraph 5.3, where it's been identified there are a high number of incidents related to handover of care at discharge. And I wonder if you could just say a little more about that and about what is being done.
Absolutely. Probably Gail would add more detail to that, and she's on the call as well.
Okay.
But it was work that we'd started to identify around just areas where we could make some improvements in discharge, and some of that had arisen through some of our complaints work. But Gail, I wonder if you would want to add any more to that.
Sorry, could you just repeat the question, please?
It's at paragraph 5.3. There's a reference to the high number of incidents related to handover of care at discharge. And I just wanted a wee bit more clarity about what you mean by a high number and what's being done to address that.
Okay, so basically what we notice is sometimes when somebody moves from hospital into the community, into a care home or into the community with a package of care, sometimes that doesn't go as smoothly as we would like. So what we've done is we've pulled together a team of a range of individuals, including the third independent sector representative. We've sought to understand what some of those situations have entailed. So as well as looking at each incident individually as it happens, as is normally done, we've taken the opportunity to take a holistic look at it to see what are the common themes, so we can seek to address those common themes early on. So one of the things that come across is the need for effective communication. Sometimes the communications could be better in relation to the various handovers across different teams. So that's a key area. There's also been a sort of common theme around the discharge letter that goes out with people, making sure it's timely and contains all the information that's required. So by taking a learning approach, it's hope we can focus in on the themes that we're noticing to improve the processes and systems to reduce the number of discharges that happen that aren't as smooth as we'd like them to be.
Okay, thank you. That's always a theme, isn't it? The issues about communication and ensuring smooth communications happen. But just glad to hear that it's being addressed and looked at holistically, not just in relation to the individual cases. Thank you very much. Anybody else got any questions or comments? I've got Roger with his hand up. Roger Ridley.
Thanks, Chair. A couple of questions for you, Suzanne. Firstly, it always occurs to me in relation to section 10, that the health services have quite a good system of supporting staff through the process when there's been a suicide or a drug death or even an alcohol death. But the council don't have the same support procedures for staff, and I was wondering whether there's a chance that these could be merged so that the system that the health services has, and which sometimes we piggyback on the back of as council workers, whether there could be a clear system, a joint system for the Health and Social Care Partnership, where obviously these can be very stressful times, these investigations and things can be very stressful times for staff, and it's really important to support staff through these events. I wonder if there's any way we can develop that.
I can certainly take those comments back, Roger. I think that's a really helpful observation. I know there's been lots of joint work being done through the sort of Falkirk approach, but we can certainly take that through comments back to Elaine Brown and Martin. I don't know if you would want to add anything more to that.
Sorry, could you repeat that, Suzanne? I couldn't hear you there. My internet's pretty weak today.
Roger was making a point about how we support our council staff and colleagues if there are any sort of drug-related deaths or suicide-related death review incidents, and how we could perhaps look at that in collaboration with our council colleagues and have an HSCP approach. I hope I've reflected that correctly, Roger.
There is.
Yeah, they have a good system in the health service. And it's very supportive of staff from my experience, but there's no equivalent in the council.
There is a bit of work going on looking at how we can share the learning from those reviews more widely. It's fairly early days for the group coming together, and there has been quite significant learning that's been shared across partner agencies that have been specifically involved in some cases. But now that we have the ADP lead officer in post and the suicide prevention officer, the plans are to take that learning and share it on a more regular basis. There's also a request for some more oversight from the Chief Officers Group as well in relation to this, and the plan would be to share that learning much wider across partnerships going forward. We are looking at how we can develop that programme along with the review of the ADP and other areas of work. But really, I agree, we need to make sure that frontline staff hear these lessons from all our learning reviews, not just in relation to the drug-related deaths and the suicide work, but also in terms of significant case reviews, etc. So we are doing a bit of work looking at how we can share that learning much wider. I suppose that was part of the reason that we'd established the Clinical Care Governance Management Group, so that we could look at that learning as a collective group in terms of the partnership leadership team, and then take that learning back to staff. We just need to finalise the processes for doing that, but it's definitely a work in progress, and I agree it's a really valid point, and it is in fact the whole point of those learning reviews, to share that, learn from that and change our practice. But it is very much a work in progress because it's fairly early days for these groups, but it's definitely a plan to take that forward. Hopefully that gives you some assurance that there is work being done. We're just not quite there yet, but hope to be in the very near future.
Thanks,
Thank you.
Martin.
I think if Patricia could come in on that point as well, please.
If I could, and I think, Roger, you make a really good point, and it's something that we will look at. It's one of the potential benefits of integration, that we can take good practice in one area and put it across our whole integrated team. So I'll give you that commitment that we'll explore that, and I'll pick that up with colleagues. Thank you.
I think that's.
Roger has a second question.
Sorry, do you have,
Yeah.
is that a legacy hand or a second question, Roger?
It's a second question, is the Chair. Thank you. The other was just a bit of clarification in section 7. There's a chart, I think at the bottom there, that page, and I wasn't quite understanding the figures given out there, which seem to suggest that we have about 190 people in care homes throughout. I'm maybe just misunderstanding that chart at the bottom of that page 28. Are these people who in care homes who are older people, or do they include people with a learning disability and a mental and those with mental illnesses, or and other things? What is this chart exactly saying? Could somebody say it? Thanks.
Roger, this is the data in that table is about the reviews that have been completed in the 6 monthly reviews. So there's a requirement to review residents in a care home. So that's what the data is reporting. I'll have to check if it's including older people and adults with learning disability or others, unless other colleagues on the call are aware, but I can come back to you on that.
Thanks.
Can anybody answer that, or shall we leave Suzanne to come back on that one? Okay, if you could do that, please, Suzanne. Now, I do apologise. I'm not sure whether it was Stephen McAllister first or David Heron. I think it was Stephen, so if nobody objects, I'll go to Stephen McAllister first.
Thank you, Chair. Just on the suicide and drugs deaths, but particularly suicide, the Samaritans do a lot of work in postvention and a lot of training, a lot of good access to training materials on our website. It'd be worth tying in with a local branch of the Samaritans in Falkirk to see if, I'm sure they would be willing to help in terms of supporting staff in the aftermath of any suicide related incident. It's worth having a look at.
Thank you. So Suzanne was saying she'll pick that up and pass that on. Clearly, it's important that we use all the partners in the partnership who have that area of expertise. Thank you, Stephen. And David, Dr. Heron.
Thank you. Good morning. Just going back to Gail's point, I mean, I think this is a really good area to focus on, transferring care. Medical transfers of care to general practice have been poor. There's been a lot of instances, and in fact, I think we need to go beyond just transferring inpatients. Actually, a lot of transfers of care happen with outpatient clinics, etc., and sometimes the transfers are not as good as they should be. The GP subcommittee identified this as a problem, and in fact we produced a paper that described what good transfer of care would be. We presented that to the interface group about 18 months ago. Unfortunately, the speed of change hasn't been adequate in the hospital, and I certainly welcome what the HSCP can do to assist with getting better protocols for how you transfer care to the community, because at the moment there's really tight protocols for how I'm able to transfer care to the hospital, and it does seem like there's a gap for how transfer of care out of the hospital is done. There isn't a standard, there isn't a protocol, and our secondary care colleagues sometimes seem to not be aware of what is a requirement. And we've seen as well with transfers of nursing care out to district nurses. We heard earlier this year about some instances where there was very poor transfer of care. So I think this is good that the HSCP are going to get behind this. I appreciate it's not all about medical and nursing transfer of care, but I would encourage us possibly to have a look at the GP subcommittee document about transferring care and seeing what parts of that as an HSCP we can support, and support our secondary care colleagues to implement it. Thank you.
Patricia, would you like to comment on that?
Thank you, David. I think this is a key piece of work. Gail and colleagues have already started on this with the recent workshop, doing a bit of a deep dive into this, but certainly it would be good to get a copy of that report, and we can look at how we can make some more progress with this. Thank you.
Thank you, Patricia. I think that is important, and as we said earlier on, it's one of the benefits of integration that we may be able to address it in a more holistic way, hopefully. Any other questions or comments? In that case, I think we have considered and commented on the contents of the report. So thank you very much. We will go on now to the overview of inspection reports, item 7. Yes,
Thank you.
if you would, Suzanne.
Thank you. The report presented to committee provides an update on 2 published inspections and a notice provided by national organisations of planned activity. So in relation to our inspections at section 4, provided an update on our unannounced care inspector inspection on Summerford House, and that took place on the 16th and 17th of August. The inspection considered 5 quality outcomes, and the services were assessed as 5, which is very good, against 3 of those indicators, and good, which is 4 against 2. And we've noted that at table 4.3 of the report. The inspection also noted that areas of improvement that had been identified from an earlier inspection had been met. We've also provided an update on the Mental Welfare Commission announced inspection of Hope House that took place on the 24th of August. Hope House is a 6-bedded secure female unit in Bellsdyke Hospital, and the report has set out a number of areas of good practice and also identified 4 recommendations, and those will be taken forward in the improvement plan. The report also sets out planned work that the Mental Welfare Commission have given us notice of, and that is at 4.11. So we've had our annual meeting, and we've also set out some work around community-based compulsory treatment orders work that's planned. We've also noted the establishment of an independent review of inspection, scrutiny and regulation, and that's summarised at 4.15, and we can provide further updates as that information becomes available. So in conclusion, the committee is asked to consider and comment on the report as noted at recommendation 2.1. Thank you.
Okay, thank you, Suzanne. It's obviously pleased to see that in relation to Summerford House, we get nothing but very good and good. We just need to make sure that the good becomes very good next time. Does anybody have any comments, questions? Roger, first, please.
Thanks, Chair. Just very quickly, I noticed reading this that in point 4.13, 4.13, being affected directly here, that the MWC, Mental Welfare Commission, will be doing phoning, contacting mental health officers, social workers, etc. Is there any chance of being warned centrally that this is going to happen? Because it'd be useful for, I think, frontline workers to know that they might be contacted by the Mental Welfare Commission about these things, because none of us here were aware of this.
Suzanne, or do you want to pick it up?
No. Well, the notification had come to us through the chief officer, so we would anticipate if there were any sort of any contact with a local area, that would come through that route, and at that point we would be alerting local practitioners around any requirements. So as we hear anything, Roger will let you know, but I could perhaps take that as an action just to follow up on any planned activity that's happening and let our local services know.
Thanks.
Can I clarify? This is going to be an inspection, that a piece of work that will be notified, as opposed to a surprise.
It should be, because I think it's part of a themed programme. So the Mental Welfare Commission sometimes do thematic reviews across a range of partnerships. So they might pick some areas or others.
Okay, is that okay, Roger? Happy with that? Yeah. Any other questions or comments? Okay, on that, we have then considered and commented on the content of this report. So we will move on now to the item number 8, the duty of candour annual reports. And I think, is that going to be you, Sarah? Yes.
As Chair, it's Sarah. Yep, I'm going
Sarah,
to present this report. So good morning to you and good morning to all. All health and social care services in Scotland have a duty of candour, and this came into effect in 2018. This is a legal requirement, which means that when unintended or unexpected events happen that result in death or harm as defined in the legislation, the people affected understand what's happened and receive an apology, and the organisations learn how to improve for the future. Part of our duty is that we provide an annual report about how the duty of candour is implemented in our services. The Falkirk Council Duty of Candour report is published in the Chief Social Work Officer annual report, and that's going to be presented to Falkirk Council in December, and that satisfies the requirement to publish the report. Both the Council report and NHS report are attached for your consideration at Appendix 1 and 2. Today, Clinical and Care Governance Committee is asked to consider and comment on these reports. Background to our duty of candour duties is presented at section 3, and this shows committee when the duty must be activated, both in relation to the timing of activation and the circumstances and what we are required to fulfil. Section 4 informs you that the Council's duty of candour report is subject to agreement at full council and then makes its way to the Scottish Government and will be presented to the IGB in March. There were no incidents where the duty of candour applied over the reporting period. An important aspect, however, of duty of candour is that our employees are aware of it and that they are and what they're required to do. We need to make sure that we're keeping up with learning. There are e-learning modules to support this purpose, and there's guidance, and also the Council's or our complaints procedure references duty of candour, and that makes sure that there's public awareness of this too. So Appendix 2 attached is the NHS Forth Valley Annual Duty of Candour report for 21-22. Every adverse event is reported through the NHS Forth Valley Clinical Governance Reporting Structure, and through this, incidents that trigger the duty of candour procedure are identified. The decision on whether an event activates the organisational duty of candour procedure is undertaken by the NHS Forth Valley Medical Director, who is the executive lead for clinical governance. During the reporting period, there were 9 incidents where duty of candour applied, and the report also notes that there are a further 9 reviews underway where duty of candour has not yet been established. As required, NHS Forth Valley has informed the Scottish Ministers that this report has been published on the NHS Forth Valley website, and that satisfies their requirement for publication of the report. I'll just refer committee back to the recommendations chair, and happy to take any questions, ably assisted, I believe, by Linda for questions in relation to NHS duty of candour. Thank you very much.
Okay, thank you very much, Sarah. And pleased to note that although there have been none in the Falkirk Council, no duty of candour incidents, then but you're not sitting in your laurels. You are continuing to ensure that staff and managers are being vigilant, I think is the term. Now, can I just ask one question, which it may not be yourself, Sarah? It's in terms of the incidents within the health board where a duty of candour is not yet established. I wonder if you could clarify that a little more for me, please. Would that be you, Linda?
Yes. Thank you, Councillor Hannah. Yes, duty of candour. Obviously, we have professional duty of candour where every health and social care employee has has to inform any patient or relative if any sort of harm has come to them and apologise. The organisational duty of candour has very specific criteria, which is within the legislation. So sometimes if harm has come to a patient, we don't know until we've done a full review of all the circumstances. We've looked into the event. We don't know if it was a duty of candour or if it was an adverse event that unfortunately happened just due to natural causes. Sometimes that can happen when people have got underlying health conditions. So we do a full review. We always look at our duty of candour through our significant adverse event framework, which again is a national framework that we follow all the guidance around that. And sometimes it's not until that review is actually completed that we can establish whether it was an organisational duty of candour or whether it was an unfortunate adverse event that took place. But to provide assurance, Councillor Hannah, because we go through this robust process, all the recommendations for a duty of candour take place through our significant adverse event review process. We contact the patients or families, we meet with them, we share the report with them, we produce an action plan at the end of it and share it with the teams, and we ensure that learning is shared. So even if we haven't established it during the reporting period, if we do establish it, we've covered all the criteria for the organisational duty of candour requirements because it goes through that process.
Okay, thank you very much, Linda. Any other questions? We have David Heron here first, I think.
Yeah, I suppose just a positive comment. I think the SAER process, I think I've been involved as one of the reviewers, and it's a painful process looking back on these events, but you know, I've been impressed with how professionally run it's been, the depth with which we look into these cases, and the reports that we produce from them hopefully can lead to changes, and I think the process has been run very well. We've got sort of professional reviewers who sort of lead the process, and we get people in from the different specialities involved. So I've certainly found it quite a positive process. Thank you.
Thank you for that. Yes, and the changes that have been highlighted in the appendix in terms of the learning process. Any other questions or comments? Okay, in that case, as recommended, we have considered and commented on the report, and we can move on now to agenda item number 9. And I think this is back to you, Gordon, in this case. Am I right? Or
well, myself and Mandy. Mandy's joined us to deal with the
okay.
NHS complaints. Mandy, it's okay with you. I'll go first. If that...
Perfect, Gordon.
Right.
Thank you.
Thank you, Chair. Thank you, committee. Unfortunately, this is from the social work adult services point of view. This is not a good report, not one that I would have wanted to bring to you. The figures in the table at 4.3 show a significant decline in the number of complaints completed within timescale. Give you a bit of background on this. About 18 months, 2 years ago, our figures for stage 1 reporting within timescale were languishing down around in the low 50s. And we did a bit of work then, quite a bit of work then with frontline managers about how to respond to complaints, the different ways of, it's quite a clunky sort of complaints software that we're using, but impressing upon them the importance of responding to complaints within timescale. And we saw a significant improvement for the year April 21 to March 22. The performance rose to about 79%, I think it is, and 77%, sorry. However, we've seen a steady decline over the last few quarters, and to be honest, I think, yes, we need to have a refresh of this, but the complaints performance in the last quarter, the quarter which we're reporting, shows quite a substantial decline. And so we've instituted a number of actions which trailed at 4.9 in the report. Basically, we're going back to individual managers. We've done a session already with the community care team managers who are responsible for complaints about the importance of complaints, going through some of the detail of complaints mechanism, how to ensure that you don't get caught out timing wise, that sort of thing. But it comes down to individual workloads and individual responsibility to complete the responses within time. So locality managers, myself included, and senior service managers, we've given the details on individual performance, and we're following that up with the managers themselves to see what advice, guidance or support they need in order to complete a far higher percentage of complaints within timescale. That's really it in a nutshell. I think that's the main points I wanted to get across today. Unfortunately, given the time lag, it's probably going to be 2 quarters before we see a significant improvement. Again, I'm absolutely determined to ensure that there will be a significant improvement, but we're already partway through this quarter, so I'm not expecting to see an immediate improvement that will come through in the figures, but definitely within 2 quarters I would be expecting to see the figures go back up into the 60s and hopefully into the 70s. That's my part of the complaint report. Probably best if we take questions on this first and then hand over to Mandy, I might suggest.
Okay, we can do that. And clearly it's very disappointing to see the lack of improvement going, the deterioration in the procedure, because complaints procedures are really important because they enable us to learn from where things have not gone as we would have hoped they would. So it is, as you say, a disappointing report. Do we have any questions on what Gordon has covered so far before we go over to Mandy? I think, Roger, you came first. Roger Ridley, if you please.
Thanks, Chair. Just very quickly, I find it quite helpful in the health side of this report, table 3 there, just charts a bit about whether the complaints are coming in. I was wondering whether there's any chance of having a similar table for the social work side of complaints.
Yes, Roger, we can. Sorry.
Can you answer that then, please? Yes, go ahead.
Yes, we'll get something together on that, Roger, for the next report.
I think that's a good point, that this is health and social care partnership and we should try to look at the two together if we can. Margot.
Just to say, perhaps I should leave this till after Mandy has had a chance to speak and the care opinion report, but would you agree that one of the factors in this is the fact that care opinions perhaps dealing with some of the less complex issues and settling them, and secondly, that what the actual process is, the complex cases are the ones which are taking the time to investigate and settle, and that's slightly skewing the result.
Unfortunately, that's not the case. The stage 2 reports, if you look at the table, the stage 1 reports are the less complex. The stage 2 reports are the ones that are more complex, and there is a greater time scale given for those. It's 20 days, 20 working days for stage 2 to take account of that. They're much smaller in number, and there's a relatively good performance there. I think over the year it's about 86% performance on stage 2 at the moment. So the stage 2 part of it is not so bad. It's better than it has been, but the stage 1 is where we are. Part of the discussion with individual managers about individual complaints is about, is that complex complaint that needs to be moved to a stage 2, and we can do that, but it's not coming through to me that is the issue. The issue is about prioritization of complaints amongst many other things that managers are having to deal with. But as the chair has said at the start earlier on, complaints are really important for learning. When something has gone wrong or may have gone wrong, the first thing we need to do is respond to people in a timely manner. So thank you for that suggestion, Margot, but I think we need to look at how we're dealing with the stage 1 complaints, the straightforward ones.
Thank you.
Thank you, Gordon. Mandy, would you like to come in at that point?
Absolutely. Good morning, everybody. I've got a bit of a mixed bag this morning for you. Some good news and some not so good news. So between April and September, a total of 13 complaints have been received with regards to the delegated functions for the partnership, and overall end of year performance for both stage 1 and stage 2 combined, sitting currently at 69.2. During September, the partnership received 2 stage 1 complaints and achieved a 100% performance, which is fantastic. However, the stage 2 performance has dropped to 60% at the moment. For me, that's indicative across what's going across the whole organisation within NHS Forth Valley. Stage 2 performance has dipped because of the difficulties that conflicting priorities, and our complaints at stage 2 we're seeing a lot more complex complaints coming in, managing lots of different areas. However, the good news for September is that the 9 complaints that were received in for Q2, sorry, I'm saying September, but it's Q2, none of them were upheld. They were all not upheld. The top 3 themes at the moment for the year so far is staff attitude and behaviour, communication where patients and families feel they're not being given the full information, and patient privacy and dignity as well. Out of the 17 departments, only 4 have received complaints so far this year: Woodlands, District Nursing, AHP Outpatients Care Group, and Thistle Suite. Like I say, the good news is that all the complaints, there's a high percentage, are not upheld. With regards to the Ombudsman, this is also a good news. There has been no complaints received this year so far from the Ombudsman regarding the partnership, so I think that should be celebrated as well. And that's all I have to say from the health side of things. Thank you. Happy to take questions.
Thank you, Mandy. As you say, it's a mixed bag, but
yeah,
not happy reading.
No.
Can I just ask you to say a little about what learning has come from the complaints that there have been, and where?
So this quarter there hasn't been any learning, so none of the complaints were upheld, which means that there was no learning for staff to instill. I can do a pool and actually put into the report for you for the next time round for overall learning, but for Q2 there was no learning at all to be had because the complaints weren't upheld.
I think that is important that we
Yeah.
learning.
Absolutely.
That's what the whole procedure is about, to try and avoid there being any complaints. Anyone else have any questions? Okay, in that case, we have considered and commented on the content of this report. Sorry. Oh, sorry, I missed that, Margot.
No, I realised I should have waited till after Mandy made her presentation.
Right, that's okay.
And also, I would just say, and I'm always saying this, I think, and we'll see this in the presentation for care opinion, some of the complaints are deflected through there being a sort of resolution at care opinion level. But I would also wonder what effect the shared care, and I'm always making this point, is having on the complex cases. Do you find that some of your partners in other centres of care are as prompt as they should be for reaching a resolution of particularly significant event type complaints?
I think there's actually a very quick response with the big complex complaints. The first thing within patient relations and staff across NHS Forth Valley is that we get them in for a meeting and do a face-to-face meeting rather than making them wait the 20 working days to get a written letter. Meetings were put on hold for a bit during COVID. However, they've stepped up significantly. And also I have a close working relationship with Linda's team, where we sort of discuss high profile complex complaints and whether they're going through the SAER process or not. So we've got a lined up approach with regards to the big complex complaints, Margot, and hope to get early resolution as quickly as possible.
Thank you.
Okay, thanks guys. Have a good rest of your meeting.
Thank you. Thank you very much, Mandy. And so I'll now say that we've considered and commented on the content of the report and the actions taken. And we will move on to agenda item number 10, the care opinion report. And I think that is Leslie that will be speaking to that report. Am I right?
Yes. Thank you. Sorry. Thanks. The purpose of this report is to provide committee members with information about care opinion, which the senior leadership team have recently agreed to be implemented across the Health and Social Care Partnership. So Care Opinion is an online platform where people can provide feedback about their experience of health services and also care inspectorate registered social care services. Regular reports are then generated to give the partnership an overview of response themes, areas of good practice and also improvements. And obviously, staff from within teams are able to provide a response to the feedback provided by service users. Care Opinion supports the commitments outlined within our participation engagement strategy by ensuring that the partnership providers have independent mechanism to engage with a wide range of people. This will drive forward quality service improvement and build a reputation for openness and transparency across the partnership. It's important to note that all stories are moderated by Care Opinion before being published, and this may include contacting the author directly to ask for clarification around the points raised. Care Opinion also remove any profanities and discriminatory language from feedback. Stories are also categorised with a criticality rating of between 1 and 5, 1 being very positive. If any stories are assigned a rating of 4 or 5, the partnership will be contacted and provided an opportunity to consider their response before the story is actually published. The implementation process requires a significant planning and resource, and an implementation group has been established, including representatives from localities, performance, commission services and communications. The NHS Forth Valley Patient Experience Manager is also involved, and NHS Forth Valley have been using Care Opinion for 6 years, so there's fantastic experience and learning to be taken from that. We are in the process at the moment of mapping out all of our current partnership services and identifying leads who will be responders to the stories. Communication and training will be absolutely critical in the implementation. Staff need to feel confident and supported in providing responses, and we will take the time that's required to ensure this is the case. Initially, team managers will be responders, but as time goes on, we would want to develop expertise within frontline staff to also be able to respond as well. At this time, due to the kind of the detailed process around about implementation, we are planning to launch Care Opinion around about May 2023. I'm happy to take any questions.
Thank you very much, Leslie. Any questions or comments from anyone? Roger Ridley again.
Thanks, Chair. Just very quickly, thanks, Leslie. I'm pretty positive about the rollout of this project. Just you're saying and you emphasised there, so thank you for that, that engagement with staff is going to be really important. Can I just check that the unions will be involved in that engagement process?
Absolutely, yes, and we'll follow the process that NHS Forth Valley took in terms of their implementation. So yeah, so we'll engage as and when is relevant. I would have to stress that we're at very early stages at the moment. So the implementation group has literally met once. So once we're a little bit further forward, we'll be in touch as necessary.
Great, thanks.
I think Patricia would like to make a comment too.
I think Leslie and Roger, it'd be helpful just to put that on the agenda for the next Joint Staff Forum so that we can give the Joint Staff Forum an update on this. I think that'd be helpful.
Thank you, Patricia. Anybody else, any comments or questions? I think this is a really interesting development and another way in which we can learn perhaps from the stories that people have to tell. So I think they have now considered and commented on the report. So thank you very much, Leslie, and we look forward to hearing more when it's gone further forward. So we'll now go on to agenda item 11. That's the hospital acquired. Oh, sorry.
Jonathan's here.
Jonathan's here for this item. So the hospital acquired infection performance report. If you would like to take that away, Jonathan.
Okay, thank you, Chair, and good morning, everyone. So this is the quarterly report for July to September this year. Overall, just give you a quick overall, it's been relatively quiet this quarter, so which is good, and I'll explain a few of the things throughout my presentation. First, starting on the situation with COVID at the moment. At the start of this quarter, we had within the hospital setting around about at most around about the mid-60s inpatients, which is quite high, higher than what we would like. But over the course of the quarter, we'd seen a general decline now. And just to give you an update of where we are currently, we have 14 patients in the hospital now with COVID. So numbers have certainly reduced now. You know, we're heading in the right direction here. Major changes within the guidance this quarter was to do with stopping asymptomatic testing. So in the past, anybody admitted into the hospital setting was screened for COVID, and this is probably why as well our numbers are lower now. So we're not picking up old infections, because the limitations of the PCR test that we do, it will pick up old virus for up to 90 days past infection. So that was one of the major changes, and also asymptomatic testing on frontline staff as well. So that's where we are at the moment with COVID. In terms of our hospital onset COVIDs, so these are the ones that are classified nationally as those that are acquired within hospital during their stay and not developed in the community before coming in. So we were sitting at 17% compared to the national rate of 24.7%, so which is good. Unfortunately, now the national data has changed, and the comparative tables now that they're producing, because of the change of the asymptomatic testing, some boards are doing differently. So we're comparing apples with pears now. So I won't be including the table on page 4. Because it doesn't really give you a great deal of detail in terms of a national comparison of how well we're doing compared to other boards. But as you can see in the table for this period, that we were sitting comfortably lower than the rest of the boards across Scotland, with the exceptions of Dumfries and Galloway, so and the island boards. So we've always been and remained in that kind of category ever since throughout the pandemic. Just to give you a quick update on the standards and guidelines that have been changed, and HAI ones as a whole. I mean, in May this year, that we saw the new HAI standards that applied both to the hospital settings and beyond and further, including the care homes. The care inspector are actually leading this to embed, but we're also providing support, to care homes where needed. Moving on to the annual operating plan targets, as you're aware, I mentioned this at the last meeting there, this target was originally set for March 2022, but was extended due to the pandemic, so it's extended to March 23. So there are 3 targets: the E. coli bacteremias, Staph aureus bacteremias, and Clostridioides difficile infections. So for our E. coli ones, and I've mentioned this before, we have particular challenges around achieving this target. Our primary challenge around this is those infections that are acquired at home, and instead of, rather than being infections developing in the hospital. So that's our biggest challenge, and the predominant infections that are related to these are lower urinary tract infections and biliary associated infections. So those are patients coming in with gallstones and so on, and urinary catheters. So we've done a bit of work looking at the ones in the community. We've looked at the biliary sepsis, and from an infection prevention point of view, there's nothing that we can see that we could limit this. This is all based on individuals' diets, and all those kind of things can exacerbate gallstones and so on. So it's a very challenging thing. We are trying to, from the hospital point of view, turn around these patients very quickly and have some surgical interventions. Currently when patients come in with a blocked gallbladder, they generally don't get any surgical interventions at the time. They've got to wait for inflammation to die down, and as a result of that, we're trying to turn around these patients sooner rather than later, so we can help speed people up and stop having people having recurrent infections. With the urinary catheter ones, we've had a look at those patients who are cared for out in the community, and we found no evidence to suggest that there's any improvements that can be made. The district nursing, from looking at their notes and the interventions that they put in, shows that there are good practices being undertaken out in the community, which is really reassuring. For our Staph aureus bacteremia targets, we're quite comfortable, and we anticipate that we'll achieve that target by March 2023. For our Clostridioides difficile rates, we're a little bit above trajectory at the moment. We had a couple of peaks in this quarter, or one peak in the quarter, and we're doing a bit of work around that. We do believe that Clostridium difficile now can be associated with seasonal variation as well. So I can talk to you a little bit more about that later on in this document. So moving on to specifics of the Staph aureus bacteremias, again, we saw a decrease this quarter. We had 6 reported cases compared to 16 between, in April and June, which is a good reduction. Within Falkirk Community and Bowness Community Hospitals, there were no reported cases for this quarter. Our device-associated bacteremias, again, we've seen a reduction this quarter. We had 16 reported cases compared to 21 in the previous quarter. And again, Falkirk and Bowness, there were no reported cases here, which is good. Our E. coli's, like I said, our numbers remain quite high, and you can see in the graph on page 10 that we did exceed our control limits there. So we're doing quite a bit of work around that. We do submit, when we do exceed our control limits, we do report to RHI Scotland, which is our national part of National Services Scotland, who oversee our targets and our mandatory reporting, and they're quite satisfied with the work we've done and do recognise that there are challenges out with the control of the infection prevention control teams. Our Clostridioides difficile infections, again, remain stable. We had 11 reported cases, and that's the same as the previous quarter. We had no reported hospital Clostridium difficile infections, which is good. Moving on to the estate and cleaning compliances, overall the board-wide totals remain very consistent for their Falkirk ones. Our cleaning scores remain good at 94%. Our estate scores remain slightly below the 90% that we would like to see. We're sitting at 88%, but you can see in the last 4 quarters that we remain very consistent. Our Bowness hospital scores also remain relatively consistent and in the green. Finally, moving on to incidents and outbreaks. I mean, in total across the hospital settings, we had 7 reported outbreaks over the quarter, but there were no reported outbreaks in either Bowness or Falkirk Community Hospitals. So that's the end of the report. So I'd be quite happy to take any questions. Thank you.
Thank you, Jonathan. I would just like to start by asking about the E. coli, because that seems to be consistently above the average.
It does, yes. And
Quite some time, and just to say a little bit more about what is happening to identify reasons and address it.
Yes. So what we've done, so we know nationally, we have a 25% reduction, on our E. coli. The reason why E. coli in particular, E. coli is an organism that's just give you a bit of background to E. coli, or Escherichia coli as they hear. It's not the E. coli that causes these big outbreaks you hear in food places and so on. It's not that kind of, that's a variant of the E. coli. This E. coli is an organism that inhabits the gut, and it's quite ubiquitous within the gut. Just to give you an idea, the number of organisms in the gut, in 1 gram of feces, there's 10 to the power of 9 E. coli bacteriums in there. So a huge amount of organisms in there. And as a consequence, it's the most common organism that causes urinary tract infections and so on. So and because it lives in the gut, it can cause other issues such as like biliary tract infections and so on. So what we're finding within the hospital setting, arguably probably the most common, so looking at organism infections that we can actually reduce, which are reducible, arguably are urinary catheters, certainly within the healthcare setting. And we're kind of unfortunate, but fortunate in some ways as well. We also, like I mentioned about the device-associated bacteremias, then that would also include urinary catheters. Now, that's not a national requirement. That's something that we've been doing uniquely in Forth Valley, and it's unique in Scotland, what we're doing, because we felt that rather chasing specific organisms, that we were chasing the procedures and the types of things. That's why we're looking at device-associated bacteremias, but in that was urinary catheters. So we've been doing work on catheter reduction since 2014. So our hospital rates have reduced quite significantly since then, even before we even started looking at E. coli. So from the hospital side of things, we do find it quite challenging to reduce it, bearing in mind that people do get infections with any device that's in situ, because it's a great access point for bacteria and especially because like for urinary catheters and the location of it, and with all the E. coli present in feces and what have you, it is a very common organism that does cause infections. The biliary sepsis is the biggest challenge that we do have, and we looked at that. We found that 50% of all patients were known to have gallstones. Maybe the prior, a few months to a couple of years prior to their infection. And what happens, sometimes they are conservatively managed if patients reduce their fat intake and all that kind of thing, have a better diet, then that can reduce the likelihood of the gallstones developing and blocking the gallbladder, which could then lead to infection. So we've looked into that, and we couldn't find anything from an infection prevention point of view, but we have shared our data with the surgical teams, and they're trying to get a turnaround time to improve the turnaround time. So when patient does present with sepsis, quite often they can't operate on the gallstones because due to the inflammation and things. And so what happens, the patient once everything's settled, there's antibiotics, pain relief and what have you. Once that settles down, then they're asked to come back to have that interventional surgery to remove the gallbladder or what have you, put a stent in and things like that. So you can't generally do it when, as they describe, the gallbladder is hot, if you like. So it's called a hot gallbladder when there's inflammation. So they're trying to turn around that time from initial diagnosis to surgical intervention. So work's ongoing with that, and our associate medical director is leading on that. In addition to that, we are in the process of procuring particular surgical instruments that will be able to operate at that time of inflammation and at that time of acute infection. So we're hoping that those kind of factors will actually reduce the numbers of biliary sepsis going forward. In terms of what numbers, I couldn't tell you. I don't know. We'll have to wait and see about that, because it's very difficult to pull that data, you know, whether or not a surgical intervention sooner would have reduce the likelihood of that infection, bearing in mind that 50% of all the patients that we do receive have had no previous medical history of gallstones either. So it's a difficult one. You know, urinary tract infections is another one that's very common. And these are people, when you have a normal urinary tract infection, sometimes it can progress and lead into sepsis, and that's predominantly out in the community, and which is very difficult. There were national campaigns like the hydration campaign about, you know, encouraging patients to, or members of the public to monitor the color of their urine. If you like, if it's too dark, then they need to drink more water, because we know that, you know, if you become dehydrated, you're more likely to become infected with the UTI, and then the consequence of that is you know, potentially you know, systemic infection as well. So, and I did mention about the urinary catheters as well out in the community. We did look at this, and we've got a system called Track Care, which we monitor, you know, which has got a raft of information, including the district nursing notes as well. So we've traced back of all these patients who have been positive, you know, have come in with catheter associated bacteremias, and we looked into that, and from what we can see, that there was no reason for any improvement that we could see from the district nurses. We could see on the day that the patients made contact with the district nurse then attends the patient that day, because you can see this all logged on our Track Care system. And you know, and
You'd be very thorough, but
oh, okay, sorry. I just thought I'd answer your question. So yes. To summarise, we're doing a lot of work around it, you know, but we do recognise there is a big challenge. Our High Scotland are national people who are aware of what the work we're doing, and they're quite satisfied with what we're doing. So I'll be quiet now. Sorry.
Okay, thank you very much. Margot, you've got your hand up.
Well, it actually kind of follows on from your question. But in the interests of the patients that I represent and for my own learning curve, ISOM 5.1 about sepsis and the number of cases which are developing, I don't know if it's within the remit that you follow, but I just wondered how much monitoring to prevent the development of sepsis goes on in hospital, because we're seeing from a public perspective these public information films about the symptoms of sepsis, and I used to be on Dan Beckett's sepsis group, and I just am conscious of the speed with which, if you tackle it, you may prevent it from becoming devastating with amputations, etc., or death resulting. So I just really wondered if part of your remit is seeing about this, although it's, I know, not one of the headings, but I know that the link's there in 5.1.
I think from what you're saying, we use a tool called the Sepsis 6 protocol. So there's a checklist, and you know, so if patients trigger temperature or Igering or whatever, a blood culture is taken, you know. So I think as soon as that started, we are taking more blood cultures, and so we are picking up more, but also our machines within the microbiology lab are now become more sensitive as well. So we're picking up more things, which is good. It's good for the patient, you know, but as a consequence of that, we are identifying more infections as well. But that's you know, it's not so good for the numbers and the targets, but it's good for the patient in the first term. Yeah.
Thank you very much.
Okay.
Thank you. Has anyone else got any other questions or comments? No. In that case, I think we have considered and commented on the report. Thank you very much, Jonathan.
Thank
you. And we'll move on to agenda item number 12, Clinical and Care Governance Committee governance. not easy for you to see. So I think that's Dave that's going to speak to that one.
Yes, thank you very much, Chair. And the purpose of this report is to propose a programme of meetings for the committee and an indicative forward planner for 2023. So I'll just draw your attention to section 4, the proposed meeting dates for 2023, all starting at 9:30 AM are the 24th of March, 23rd of June, 22nd September and 24th of November. The CCGC's previously agreed a forward planner, and this aims to ensure the committee is compliant with the Falkirk Clinical and Care Governance Framework in terms of reference, and you can see the draft forward planner for 2023 attached to Appendix 1. Obviously, this is just a draft and it's a working document. Some reports will change, but it gives us an indicative work plan for 2023. If I draw your attention to section 5, so following the end of the COVID-19 related social distancing restrictions, the Integration Joint Board agreed in June 2022 to meet virtually for the remainder of the year and to consult members on future meeting arrangements. That consultation has since taken place, and the board agreed at its meeting last Friday that the meeting arrangements for board and committees will be on a hybrid basis, and it will use Forth Valley College for our Q1 meeting so that we can review that proposal, see if it works for the board or not, and then we can make a decision again. The board will make a decision again at the end of Q1 about how it wants to move forward. So just to go back to the recommendations, we're just asking the committee to agree the programme of meetings for 2023 and consider and comment on the draft forward plan for 2023. Thank you, Chair.
Okay, thank you, David. Does anyone have any questions or comments? And can we agree the programme of meetings for 2023? Everyone in agreement? I see no one saying otherwise. So we have considered and not commented on the draft forward planner for 2023. So can I assume that that is, everybody's quite comfortable with that? Thank you very much. So agenda item number 13, the overview of national publications. And this is again you, David, I think.
Yes, thank you very much, Chair. I'm used to speaking twice at a committee meeting. Usually I'm the person, the wee quiet boy, that takes notes in the corner and operates Teams, but moving on up. So this report provides an overview of national reports that are relevant to the partnership that have been published since the last committee meeting on the 26th of August. We have a total of 7 reports that have been published. So the reason that we have this report is that the committee's received a regular overview report since 2020, where there have been publications of relevance to the partnership. This arrangement recognised the national publications may need to be considered across a wide range of settings, such as the IJB or Audit Committee, depending on the nature of the reports. And where those reports are not considered by the IJB or Audit Committee, a summary of those reports will be included in the overview report. Committee members can always highlight if they think they need more detailed consideration of any report, and if so, what the appropriate reporting route would be. At section 4, we have an outline of the reports at the table there, and you can see we have reports from the Mental Welfare Commission, Scottish Government, and the Scottish Parliament Health and Social Care Sport Committee. And there's an executive summary provided at section 4, and if you can click on the link, you'll find the full report, which you can read in more detail. And we're just asking the board to consider and comment on the content of this report. Thank you.
Okay, thank you, David. Does anyone have any questions or comments on the report? In that case, I think we can say we've considered and not commented on the report. So thank you. That was the last item on the agenda. And this is, of course, the last CCG meeting of this year. It seems a bit early to be wishing you all a Merry Christmas and a Happy New Year. But for those of you that I may not see between now and then, I do wish you that. And a healthy and happy holiday period when it comes. And I look forward to seeing you all in March 2023. So thank you very much, everyone.